Hi, I'm Pat Anderson, editor of MIMS Learning, and I wanted to tell you a little bit about the MIMS Learning subscription. This annual subscription gives you full access to exclusive subscriber content, ranging from clinical reviews to extended learning and recordings of our webinars. So come and check it out. If you take out a subscription, you'll find that it gives you stimulating learning, keeps you up to date on all the hot topics, and helps you with your appraisal process. So have a look today at the MIMS Learning subscription. You'll find it'll really add value to your learning. Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Pat Anderson, editor of MIMS Learning, and today I'm absolutely delighted to have with me Dr Toni Hazell, who we have known for many years and who's going to talk to us today about obesity, weight loss drugs and women's health, including contraception and HRT. So welcome, Toni.
Thank you very much, Pat. Thanks so much for asking me.
Could you just tell us a little bit about yourself and your involvement with the Primary Care Women's Health Society?
Yes, absolutely. So I've been a GP for just over 20 years and I've spent all of that time in Tottenham in quite a deprived area of London. For about the last 8 years or so, I've been a portfolio GP. So I've got interests in education, in women's health. I'm an appraiser. I'm chair of my local medical committee and I do a lot of freelance medical writing and speaking at conferences for MIMS and for other providers. And I've been involved with the Primary Care Women's Health Society, which has just rebranded from the Primary Care Women's Health Forum, for several years. It aims to enhance women's quality of life by empowering primary healthcare professionals with the knowledge and the resources that they need to deliver exceptional care, aimed at grassroots professionals in primary care. And as part of this, we turned around quite quickly a document about the new weight loss injections, the GLP-1 agonists, and their effects on contraception and HRT very soon after the British Menopause Society brought out their guidance. And we also provide lots of other online and face-to-face education.
Brilliant, thank you. So we're going to talk about injectable weight loss drugs and women's health. What's the background to all of this?
So obesity is a really big health issue. We know that about a quarter of adults are living with obesity, about 2/3 with overweight or obesity, probably about 1 in 8 children under 10. And we all know about the health consequences of this in terms of diabetes, cardiovascular disease, but also cancers, which I think people don't maybe think of so much, particularly from a woman's health perspective, endometrial and breast cancer. And I think there is a really clear need to see this as the medical problem that it is, rather than perpetuating this stigma that people are just lazy and greedy and they don't understand. And if they did understand, then they'd behave better, because that's obviously not true. There are plenty of medical professionals who are overweight or who are affected by obesity. We know now that it is much more complex than that. There's complex interactions of the different hormones that govern hunger and satiety, which make it extremely difficult to lose weight if you have been affected by obesity for some long period of time. And some of the stories that I've heard from patients and from other organisations when I've been doing an education in this area about the stigma they've had from healthcare professionals about obesity have been really heartbreaking. So on the background of this, I guess the history is that there have been weight loss drugs in the past. Some of them have been derivatives of amphetamines and have given the sort of predictable consequences of that, sometimes very dangerous. But recently we have these GLP-1 agonists which bind to and activate the GLP-1 receptor, and that increases insulin secretion, suppresses glucagon secretion, and slows gastric emptying. So they were initially around for diabetes. They've been around for diabetes for a long time, and it was noted that people lost weight. And more recently, there is nice guidance and licenses for weight loss. So I think I will probably mainly talk about semaglutide, which is the main GLP-1 receptor, and tirzepatide, which is a joint GLP-1 and GIP receptor agonists, the GIP bit, giving some sort of central effects on what's called food noise, that kind of really the behavioural aspects around obesity and the constant thought about food, even when the person isn't necessarily actually hungry, which leads to maladaptive eating behaviours because these thoughts are so intrusive. And these drugs seem to be an absolute game changer. Previous drugs haven't, in my experience, worked particularly well. I've had quite a few patients who have lost some weight on orlistat, but at the cost of very nasty side effects, and it always seems to have come back on after they've stopped taking it. But these drugs do seem to be a bit of a game changer, but as always, it's how you roll it out, how it's happening privately, and how it's happening in a resource-limited system such as the NHS.
And where does the women's health angle come in? Is it because there's been increasing use of the newer drugs, and it's great to hear that they are being more effective, and then there's been discovery of the impact on women who are taking hormones? Is that what's happened?
Yeah, basically. So the first thing, obviously, any drug taken by a woman of reproductive age, you have to think about pregnancy and the pregnancy risk. BNF just says avoid them in pregnancy, citing toxicity in animal studies. The BNF is often not terribly nuanced on pregnancy and breastfeeding advice, so people tend to look at other resources, and UKTIS, the UK Teratology Information Service, it notes that, of course, the evidence is limited because they haven't been used that much, and probably the cohort using them for obesity are maybe more likely to be women of reproductive age than the cohort using them for diabetes, who possibly on average will be a bit older, just thinking from general experience. Theoretically, UKTIS says that they have a high molecular mass, so there shouldn't be any transfer across the placenta. There's no data showing any causal relationship to bad outcomes. And so certainly incidental exposure in early pregnancy is not grounds for an abortion, and not even grounds for any sort of increased monitoring or increased scans or anything. But of course, we don't really know, and we tend to err on the side of caution. There is slight concern that exposure close to delivery might lead to neonatal hypoglycemia, but obviously that's not so much an issue for risk of accidental exposure because women tend to have noticed by the time they get to 7-8 months pregnant. I certainly have done. We also obviously have to set that against the known consequences of obesity for pregnant women and their babies, gestational diabetes and all of that, as well as, of course, the known consequences of obesity for the health of women in general. So if we're telling women not to get pregnant on these drugs, and indeed to have a little bit of a gap, to have a washout period of a month or two, depending on which drug it is, before they start getting pregnant, so it's recommended a month for tirzepatide and 2 months for semaglutide, then obviously they need to have reliable contraception. And earlier this year, the Faculty for Sexual and Reproductive Health, which possibly by the time of this broadcast or soon afterwards will have become the College of Sexual and Reproductive Health, issued guidance about specifically oral contraception. So there's some concerns that there is a clinically significant effect on the bioavailability of oral contraception for tirzepatide only, and therefore women should use a non-oral method for 4 weeks after they start the drug and 4 weeks after every dose increase, or they should add a barrier method such as a condom. Now, women taking tirzepatide for obesity, unless they're limited by side effects, they might well increase the dose every 4 weeks. That's quite standard. Not all people taking it do, but some do. And therefore, you've got quite a prolonged period of time when an oral contraceptive isn't necessarily going to be effective, and people might not like to use condoms, and condoms have a high failure rate. So it's certainly worth discussing changing to a non-oral method like the patch if there's no contraindications to estrogen, or the depot injection, or the implant, or the intrauterine device, or coil as patients continue to call it. It's not officially called a coil, but I don't think patients will ever stop calling it a coil. And the other issue with contraception obviously is that sometimes these medications can cause diarrhea and vomiting as a side effect, and then those women who are taking oral contraception would need to follow the normal rules about diarrhea and vomiting, although hopefully they're not relying on their oral contraception. They've got either a barrier method or they've switched.
So there must have been some sort of clinical experience of a few issues cropping up with use of oral contraception to sort of prompt this advice being given.
I think it is actually largely based on lab trials because use is reasonably limited so far, and you have to have quite a lot of people taking it over quite a long period of time to generate a proper trial. And there's all sorts of ethical issues. And at the minute you mentioned pregnancy, the FSRH actually say that the evidence is limited to pharmacokinetic studies, but it's the UK TIS who look at things like previous case reports and stuff in the absence of things like randomized control trials, which you don't generally have in pregnant women. So they tend to use all that to draw together a sort of as evidence-based as possible and kind of common sense advice. The other issue that, of course, we need to be aware of is that fertility improves weight loss. So when I see women with polycystic ovarian syndrome, which we're really beginning to understand now as a metabolic condition more than a purely gynecological one, who have a BMI in the obesity range, I do tell them that there's a fair amount of evidence that a weight loss of 5 to 10% might kickstart ovulation. And I've had quite a number of patients who have conceived whilst on the fertility clinic waiting list after weight loss. So if you've got a woman who she's maybe taken the pill for years and actually she knows she's been a bit half-hearted, she knows she's missed pills and never got pregnant, and so she thinks, well, it'll probably be fine, I don't need to bother with condoms, but she's going to lose a significant amount of weight, then that might improve her fertility such that she might be more at risk of getting pregnant.
Yeah, so it's really practical advice for GPs and other healthcare professionals about the advice to give around contraception. That's really, really useful. So where HRT is concerned, are there issues around HRT use and the weight loss drugs?
So just to give a bit of background, when a woman takes HRT, she needs to have estrogen because the problems in the menopause are caused by that age-related loss of estrogen, the female hormone. If a woman still has her uterus, so she hasn't had a hysterectomy, and you were to give her just estrogen on its own, what we call unopposed estrogen, that would lead to an unacceptable risk of endometrial hyperplasia, thickening of the endometrium, the lining of the womb, which can lead to endometrial cancer. So we give that cohort of women a progestogen as well, which doesn't treat the menopause per se, but it protects the endometrium from the effects of the estrogen. We know that oral estrogen increases your risk of venous thromboembolism. It roughly doubles the relative risk. And so obviously the absolute effect of that depends on your baseline risk. So if I buy 2 lottery tickets, I'm doubling my risk of winning the lottery, but I'm probably not going to give up the day job before the draw. If a woman has a very low background risk of venous thromboembolism, VTE, then she might think it perfectly reasonable that she wants to take oral HRT. But generally speaking, it is considered in guidelines, for example, from the British Menopause Society, the BMS, and elsewhere, that if your BMI is above 30, you should use transdermal estrogen, which is given via a patch or a gel. This can be done in the form of a combined patch, which means all of it is given via the patch. But we know that the very small increase in breast cancer risk from HRT comes largely from the progestogen. And actually, the progestogen available in current combined patches are less breast friendly, whereas micronized progesterone, which is a tablet, it's a bioidentical progesterone, and all the evidence that we have suggests that this carries a lower risk of breast cancer. And so it's a very common regime for women to be using transdermal estrogen in a patch or a gel or a spray, and an oral progesterone in the form of micronized progesterone. And you can see that if we're worried that the effective level of the progesterone might be less because of concerns about gastric emptying and because of the pharmacokinetic data that was talked about in the FSRH guidance, then you've got a woman who is on the same dose of estrogen, but effectively taking a lower dose of progesterone. And so those two hormones are imbalanced, and that causes a risk that the progesterone is not adequately protecting the endometrium. We've seen this hit the press recently, sort of over the last kind of year or so, in another way, in terms of concern about a small number of private HRT providers, and I certainly wouldn't want to tar all private providers with the same brush, because there's plenty of really good ones out there, prescribing much higher doses of estrogen without proportionally increasing the dose of progesterone, and concerns about risks of endometrial cancer in that cohort. So it's the unbalancing of the two which is a problem. So in an ideal world, a woman who is taking a GLP-1 agonist and is on HRT would probably use a levonorgestrel intrauterine device coil as the progestogenic component of the HRT. We know that these give really good protection against endometrial hyperplasia and cancer, and they also provide contraception as well. And women in the perimenopause can get pregnant, and that can be quite a significant upset to your life if you suddenly find yourself with a pregnancy and facing back to the nappy stage when your kids might be heading for university. So the levonorgestrel intrauterine device is a really great option. There are 3 brands of these available in the UK, and although their licensing varies, the FSRH says that all of the 52 milligram levonorgestrel intrauterine devices, not the lower dose ones, can be used as the progestogenic component for HRT for 5 years. So that is a really good option. But not all women want an intrauterine device. It's a slightly invasive procedure. You have this problem whereby those who didn't have a good experience having their device fitted go all over the internet and social media and tell people about it, and those who are completely happy with their intrauterine device stay quiet. So women thinking about it obviously get a skewed view. So options then would be, you could switch to a combined patch, so then the woman is getting both hormones through the skin, so they're completely balanced. That's not a problem. You're then on the slightly older progestogens, which have a somewhat higher breast cancer risk. Although having said that, the absolute increased risk of breast cancer from HRT is tiny, and the increased risk of breast cancer from obesity is much, much bigger. I often have a discussion about the menopause and HRT, particularly women who are finding that their symptoms are affecting their diet and exercise and have gained weight rapidly in the perimenopause, that sort of goes along the lines of, look, this is the risk from obesity and this is the risk from HRT. If your HRT helps you to lose weight, then your overall risk might actually reduce. So that's another thing to bring into it and to think about. But if a woman is very, very keen to stay on her micronized progesterone and has a BMI over 30, or possibly not for long if she's going to take a GLP-1 agonist, so she needs a transdermal estrogen, then there's various things you can do. And the BMS brought out some guidance earlier this year in April. So you can increase the progestogen proportionally, the oral progestogen dose, but they don't say by how much, which is fair enough because there is no guidance. But it's very difficult in primary care when a guidance just says increase the dose and it doesn't say how much. So in our Primary Care Women's Health Society guidance, which I co-authored with 3 other board members who are menopause specialists, we looked at the BMS's previous guidance on unscheduled bleeding on HRT, where they do have a table which shows how you would increase a progestogen if a woman was taking a higher dose of estrogen. So we thought that maybe pragmatically using that same guidance, increasing by that amount, would not be an unreasonable thing to do. But we were very clear that this is a data-free zone, and it's really important to tell the woman that, to share all these uncertainties with her, to explain that a levonorgestrel intrauterine device would be by far the better option, and of course to document this discussion, because as we all know, from a medical legal point of view, if something isn't written down, it didn't happen. Another option is they could use the micronized progesterone tablets vaginally. Some women do that already because they get less side effects taking them orally. The BMS guidance says that absorption and effects shouldn't be affected if you're using it vaginally, but this is unlicensed and always has been, so women need to be aware of that. I think as a sort of final uncertainty in this area where there are lots of uncertainties, is we know that women who are using HRT now probably differ from those in the historical trials. They're probably more likely to have obesity because obesity is more prevalent in the population. So again, that just makes it very difficult. And this is something where you do really need to sort of use all your consultation skills, explain to the patient, and have that balance between what you are happy to prescribe that you feel is safe for her and medical legally safe for you, whilst also obviously going with her wishes and so on. And then the final thing is we know that women with obesity are at a higher risk of endometrial cancer, and the BMS published an excellent guideline on unscheduled bleeding in primary care, which completely turned upside down the way we look at this, and gave us new sort of major and minor risk factors in order to risk stratify those who need an urgent suspected cancer referral for their unscheduled bleeding, or those who need a scan, and lots of advice about how to potentially change the HRT. They say in this new GLP-1 guidance that we should consider investigating unscheduled bleeding earlier than we would otherwise. And again, there's no data about it, but that's just one more thing to think about. And probably proactively, if someone comes in with unscheduled bleeding on HRT, and particularly if they have obesity, although even if they don't, because we've all read in the papers that some women with normal BMIs are using these drugs to take off a stone or two to be ready for the beach, to ask women proactively if they're taking these medications, because not all of the private providers write to the GP.
Yes, I've heard this, that GPs may be unaware that patients may not reveal that they're taking these drugs from a private provider. And that, I guess, puts the GP in quite a tricky position. So if, as you say, you proactively ask about it, then that covers that off. So this is really a complicated area. I'm glad to hear that there is really practical advice for GPs from the bodies that you've mentioned, which can help them find their way through. Do you ever find that women are happy with what they're doing in terms of contraception or HRT and would then just want to rethink the obesity part of the equation instead? Or are they generally so keen to lose weight that they're quite happy to adapt their contraception or HRT regime?
I haven't had many of these consultations yet. I don't think many have. I mean, I work in a very deprived area, so I was talking to colleagues in more affluent areas earlier on, and they were telling me about tens of letters a day arriving from the private providers, and it wasn't happening for us, but then it did start to happen in my area a bit later. These drugs are a real game changer, and to lose weight from established obesity by diet and exercise, of course it's possible, but it is so difficult because you have all these hormones to do with satiety and hunger. You know, hunger is such a visceral survival emotion, and when you take in all the central effects about food noise and emotional eating, eating due to boredom, eating due to stress, and then you add in the fact that we live in quite an unhealthy society where the food companies have been allowed to develop all these ultra-processed foods, which information is suggesting are almost bordering on addictive and are very difficult not to eat, but have very little nutritional benefit. I think most women, most people of either sex who have come to GLP-1 agonists have probably been trying and not managing to lose weight for years. And the success that my patients are having, I've taken a number of people off their antihypertensives or diabetes medication because they've lost 30-40% of their body weight, and their health has massively improved. And we're recording this on a boiling hot day in July, and I'm sure all those people who have lost a large amount are wandering around thinking, gosh, I would have been so much more miserable and so much hotter before I lost that weight. So it's got all sorts of effects on your self-confidence, on how you perceive yourself, on how others perceive you. So I think most women and most people are going to want to continue with the GLP-1.
So they'll be receptive to the GP's advice about other agents.
I'd hope so.
At MIMS Learning, we'd like to do more about obesity, about overcoming obesity, because there are so many people living with obesity and it's such a challenge. How do you see things developing, particularly in the intersection between obesity and women's health, in terms of new challenges and new opportunities over, say, the next year or so?
Obviously, a recent thing is the theoretical availability of these drugs on the NHS. So the thresholds that have been set by NHS England, and apologies to those in the devolved nations, but I'm a GP in England, are much higher than in the NICE guidance. So for tirzepatide, NICE recommend tirzepatide for obesity in someone who doesn't have diabetes, if they have a body mass index of at least 35, which is reduced if you're from an ethnicity that is at high risk of cardiovascular disease, and at least one weight-related comorbidity. Whereas the NHS England threshold is a BMI of 40 or greater, and 4 out of a list of 5 weight-related comorbidities, which are diabetes, raised lipids, raised blood pressure, cardiovascular disease, and sleep apnea. So other comorbidities don't count. Knee osteoarthritis, for example, very common, back pain, those sorts of things don't count. I'm hearing informally that in any given area, the number of patients that NHS England think are eligible is much smaller than the number of people that those on the ground think are eligible. So we may be storing up problems because obviously the funding that's coming from NHS England is going to be related to the number of people in an area they think will get it. And they are expecting at the moment not to reach the primary care prescribing of it as per NICE guidance for 12 years. Whether that will speed up or slow down, who knows? But it was announced in a big flourish, and it was on the front page of the BBC website and so on, and practices were absolutely inundated with calls, when in many areas the service hasn't been rolled out yet. So that's an issue. This is not something we're just going to be prescribing in primary care with no extra resources. Obviously, there's two costs. There's the cost of the drug, and then there's the cost of the professional to give it, and the counselling and the history taking and all of that, because we don't have all that spare time. A colleague of mine estimated that it might take up to 20% of their appointments, and we're just not currently sitting around twiddling our thumbs for a fifth of our time. So it is quite clear, and the commission varies by area, that either this will be resourced in primary care via an enhanced service, so there will be funding to cover the costs of the staff time and so on, or it will be done as a separate primary care service, not within the GP. It's so that in the same way as you refer someone to community services for their physio or dietitian or speech and language therapy, you might refer them to the community weight loss clinic, separate from the secondary care bariatric clinic that does bariatric surgery. So there's that issue of access on the NHS. There is a question about possibly different cohorts. These drugs aren't a really easy panacea, and we talked a bit about stigma of obesity, and a lot of people taking GLP-1s have talked about people saying that they feel they're cheating. You do have to cut down your food intake, and obviously they make it much easier because you're not hungry and you don't have that food noise. But it can be quite difficult to maintain a healthy diet if you're taking in such a small number of calories. So it is really important, for example, to eat more protein than you would otherwise. Protein's expensive, although you're eating small amounts overall, and most people notice that their grocery bills go down. If you take these medicines and you make no change to your diet, or your diet's poor and you just eat less of that poor diet, then the risk is that you lose weight, but you lose both muscle and fat, possibly too much muscle. And then if you put the weight on and what you put back on is fat, then you're in a worse position, possibly at the same weight, but more of it being fat than muscle. So really, motivation to have a good diet, even if that's difficult in how restricted it is, and to do weight-bearing exercise and specifically strength training is really, really important. And it will be interesting to see if there is a different motivational level or a different adherence to these principles between people who are paying maybe a couple of £100 a month for these medicines. And in terms of my patients, actually, sometimes really struggling to find that money, and those who aren't. So that will be interesting. And then the other issue is what happens in the long term. So I am not a sort of world-leading expert in this, but some of the studies that I've seen do suggest that when you stop, the weight goes back on. And there have been some studies that have compared those who've carried on long-term microdosing to just stopping, and it's noticeable a difference. Those with long-term microdosing keep the weight off. So these are much lower doses. So the dose of tirzepatide, the starting dose is 2.5 milligrams and it goes up to 15, and you take that once a week. And microdosing, people might take 1.25 milligrams every 2 weeks or every 4 weeks or something, which is not licensed. But I think a body of expertise is building up in this among clinical pharmacists and doctors and nurse prescribers who prescribe this, and those who are getting it privately. Many of them will then continue with long-term microdosing, and I'm not sure if the NHS has even got that far to think about that, to think about what happens, because obviously the drug costs would be quite a bit less because one pen would last a lot longer, but it's unlicensed, and you still have to have the sort of staff costs. So that's another interesting thing. Finally, the idea at the moment is that there is going to be, certainly in England, a centrally funded digital package for what they call wraparound care, which is your sort of psychological and nutrition and exercise support. And this comes back to what we were saying: how much will that be used? How much will it cost? Will it be available long term? So I think those will probably be some of the issues that we're dealing with in the future.
So it's going to be a rapidly evolving field, and more evidence is going to emerge. And meanwhile, there is going to be a lag in terms of availability for the many, many people who will actually want to benefit from, particularly from tirzepatide. So yeah, it's going to be really interesting.
And so we're going to continue getting these letters from the private companies. They're not going to stop anytime soon. And that does give us sometimes a medical legal problems, because if the letter says something like, please let us know if there are any contraindications, well, to do that, you'd have to go through every individual patient's notes, look at what else they might be taking, look at their medical history and feedback. Sometimes, again, it's a bit vague because it's all so new. So I had a patient the other day on warfarin, and my computer system sort of flagged up that there may be an interaction, and I ended up speaking to the anticoagulation clinic, and they said they're getting a bit of understanding of this and they'll talk to the patient. But how many patients have been on warfarin and a GLP-1 agonist? Probably not that many, so we don't know. And the consequences of getting your warfarin dose wrong, either in terms of clotting at one end or bleeding at another, are significant. So in the Primary Care Women's Society guidance, we put some template letters to the private companies which basically say, if we haven't flagged up a contraindication or a problem to you, that doesn't mean that one doesn't exist, because we haven't got the resources or the time to look. However, your patient probably has access to their notes via the NHS app, so you can ask them to show you that, and bouncing back the responsibility for their prescribing to them. And of course they can ask for a medical report, but that would be a chargeable private service not available on the NHS. Any consequences from the prescribing of the GLP-1 agonist lies with the private provider, but consequences of prescribing all the other stuff that we prescribe lies with us. So we do recommend that these medications are put on the computer system as hospital issue, and that is standard good practice. Patients who are on long-term medicines given in hospital, such as antiretrovirals for HIV or biologics for a variety of things, I always put them on the system as a hospital issue, because then if I prescribe something, the interactions will flag up. So we're going to have to keep doing that for a while. And we've also now been auditing our patients who are on HRT to see if there's any that we need to contact about the HRT stuff.
That's very good practical advice on both points, on the sort of managing the medico-legal risk, and also perhaps having a look at seeing who's on HRT and that you might need to contact. So, a bit of horizon scanning. Could you talk a little bit about a patient that you've learnt from in this area?
Some of my patients have lost a huge amount of weight on this, and obviously it's less invasive than bariatric surgery, and we do sometimes see regain after surgery. And so we've had consequences in terms of being able to stop significant amounts of medication. If someone comes in who's on blood pressure tablets and their presenting complaint is dizziness, it's one of my first questions, because that's often how they come to my attention. They've lost so much weight that their blood pressure control is better, but they're still taking their medicines, and every time they stand up their blood pressure falls and they feel dizzy. And I know a lot of people have come off their diabetic drugs. I'm sure there will be women who are struggling with subfertility who conceive due to this, and the risks of breast cancer and endometrial cancer and all the myriad of cancers that are related to obesity will reduce. Obviously, that takes a bit of time to feed through in figures, but it will be really interesting to see long term, over say the next 20 years, what happens to that. And there is, as I said before, just the sort of psychological benefit. People who have had obesity their entire life have dealt with the stigma of it. It's maybe stopped them doing what they wanted to do, stopped them running around in the park after their kids. They look back through their family photo albums, and it's as if they weren't there on the summer holidays, because they've always been behind the camera and never wanted to be in front of it. That's a massive benefit. And I read a really interesting article the other day thinking about the sort of wider societal issues by someone who works in the airline industry, who said that airlines are seriously considering whether they'll need less fuel in the long term as the weight of the average person decreases, which is great. I think the only industry that is struggling is the restaurants, because people are going out and sharing 3 starters between them rather than having maybe a starter and a pudding each.
Yeah, so unexpected spin-offs from what's happening. Yes, it really does sound like it's a game changer and a life changer in a way that goes beyond women's health, but it's been really, really useful to focus on women's health in this particular episode. If I challenged you to provide 3 or 4 take-home points from GPs from this discussion, what would you say?
Going back to what we talked about right at the beginning, obesity is a long-term condition. It's not a lifestyle choice. So I would say that we are still going to have patients with obesity. Not everyone can afford these. Some people get side effects, which means they end up coming off them, or they have contraindications. So the importance of trying to reduce the stigma and how we deal with patients with obesity is really important. It's not always what you say. It's kind of about how you say it. In terms of the medication, at the moment, it's really important that everyone understands in primary care that you shouldn't, as a GP, just start prescribing these. This isn't part of normal primary care unless you are resourced to do so with an enhanced service. So find out what's going on in your area and be prepared to say to patients at the moment that they're not available if they're not. And, I think many practices are actually getting their receptionists to say this, that, if you want a more general discussion about your weight and want to talk about dietitian or bariatric surgery or whatever, that's fine, but we won't put you through to a doctor to discuss these injections because they're not available. And as we said, these are a game changer. They're not going away. All the research coming out seems to be that they have other sort of side benefits, anti-inflammatory, I think bronchodilatory, all sorts of things. So the future is bright, and we'll have to see what else they do.
Excellent. Thank you very much. It's been absolute joy to have you on the podcast, and we look forward to having you back again. But for now, thank you very much, Toni. We really appreciate you spending the time to go through this important issue with us.
I've really enjoyed it. Thank you for having me.
Don't forget, you can claim CPD credits for listening to this podcast. To get your certificate, along with key learning points, you just need to go to our website at mimslearning.co.uk. You've been listening to the MIMS Learning Clinical Update podcast produced by Jude Owen. I hope you'll join us again next week for a studio discussion. Thanks for listening.